All right. So, hi, everyone. Welcome back to our travel chat. I hope you guys are as excited as I am. I know everybody's been asking for quite some time for us to have some of our embryology team members join us. And so tonight I have not brought you one, but two who have graciously agreed to join us and talk about all of the things that are so integral to what we do here at CNY Fertility, and that is everything that happens in the lab. And so tonight we have joining us Amy and Elizabeth, both of our embryologists. So Amy, why don't you introduce yourself and tell us a little bit about you?
Hi, I'm Amy. I'm an embryologist in the Buffalo lab. I've been doing embryology for quite a long time, going on 16 years. And I love what I do, and I love being a part of the CNY team. And I can't say enough about our team and helping to build your family.
So cool. Yeah. And what about you, Elizabeth?
Hi, I'm Elizabeth. I am a total lab geek. I love what I do at CNY. I've definitely been in the lab field for a while, and I feel like this was my calling, was IVF. I absolutely love it. And I'm super excited to answer questions that you guys have. I know that you don't always get to talk to us because we're kind of hidden in the lab there with our hands and our microscopes. So yeah, I'm happy to be here and be a part of this CNY team.
Yeah, it's so great. It's we were talking before we went live just about how how there's a bit of mystique behind the embryology lab, and so hopefully tonight we'll be able to answer some of y'all's questions. But we're going to start with a little bit of a question and answer that Amy and Elizabeth put together for us, given some of the more common questions that they get asked. And so and as you guys ask questions that are pertinent, we'll kind of feed those in, and then we'll of course answer questions towards the end. So Amy, I'm gonna throw this first question to you, which I get asked this question a lot, and that is, can you kind of explain to everybody watching what assisted hatching is? Why do we do it? Is it done for everybody? And what's kind of the benefit of it or the idea behind it?
Yes, I can. So assisted hatching is where we take a tiny, a little laser, and we just poke a little hole in the zona of the embryo. The zona houses the embryo until it's time to hatch and implant in the uterus. And so assisted hatching allows that embryo to easily slip out and very simply put, and attach to the uterine lining. And I would say it's good for everybody, whether it's a fresh or frozen transfer. There's no harm in doing assisted hatching. It actually helps the embryo implant.
What would be the potential harm of not doing assisted hatching where it was needed?
So in the cryopreservation process, the zona itself can sort of change composition and, for lack of a better description, harden. And so sometimes that embryo just can't, it sort of pulsates. It wants to get out of the zona and it can't easily slip out. And so without assisted hatching, it may not be able to exit the zona.
Yeah, no, that's an interesting analogy, or the term you use, because that's kind of how I was always taught, that shell, like you said, for lack of a better term, can kind of harden up in the cryopreservation process. And so there's actually real potential harm in not doing assisted hatching, whereas there's little, if any, with doing it. So I really appreciate that. That's a great explanation and a good answer to a question I get a lot. Next question is for Elizabeth. Can you kind of help us understand what you're looking at and what the difference is between a day 3 and a day 5, which is better? Kind of help us just understand why we look at embryos at those 2 stages and what it means.
Yeah. So I feel like when people ask me, and it's pretty much daily, what's better, a day 3 or a day 5, it's almost a trick question. Both day 3s and day 5s are great for transfer, and that's really important for everyone to be aware of. Now, you have to look at what's best for you. In a perfect world, if you had an unlimited number of sites to work with, certainly if we could hold them longer to day 5, 6, or 7 and see which ones blast, that would be wonderful. But all of our clients have an unlimited number to work with. So if you only have a few, a day 3 transfer would be just fine for you. That's great. The day 3 embryos are what we call cleavage stage embryos. They should be somewhere between 6 to 10 cells. And then our blastocyst embryos, at that point, they're hundreds of cells. We can clearly see 2 cell lines, the inner cell mass, which turns into the fetus, and then the trophectoderm line of cells, and that turns into the placenta. But both are great for transfer. I see tons of success on day 3s. We see tons of success on day 5s. So don't get stressed if someone's, oh, you don't have a black, that's good. It is good. It is good depending on what your cycle is and what works best for you.
Absolutely. That's such a good point too. I think there's a great risk of over comparing ourselves and our egg retrieval numbers, and though all of those things it's very easy because we don't really have a good frame of reference for these things. And so our only frame of reference is to sort of kind of bounce it off somebody else and what they did. But just understanding that a day 3 embryo might be the oldest embryo you've ever gotten. If you've been on this journey for a long time and you've never gotten pregnant, that's a big deal. That's something to be really proud of. I had a question that popped up here that is kind of pertinent to where we're at in terms of day 3 versus day 5. There's actually 2. So Amy, I don't know if you can see this question from Megan, but she's asking, what are the chances of, and I'm going to put this on the screen, of a day 3 frozen being damaged when being thawed?
So this is a great question, and we get this question a lot. I would say that 99% of the time embryos, I would say 90+% of the time embryos survive the thaw. Embryos are hardy. I can't say enough about our team. We're highly skilled in embryo survival. It does happen, and when it does happen, we very rarely call the client and let them know. But the reasons for those things could be embryo metabolism, cellular damage, like things like DNA damage or something genetic going on, that the quality of the embryo, lack of cells. But to be honest, it doesn't happen a lot. Thank God.
Yeah. And is that the same? Would you say the percentage likelihood of an embryo not surviving the thaw would be about the same between a day 3 and a day 5?
Yeah, I do.
The same risks that exist for the day 3 would kind of be there.
I mean, I see them to be about the same survival. Do you, Elizabeth?
Yes. Yep. I agree. I think you had said 99 and then said greater than 90, but I think she meant to say greater than 99%. Almost all of our embryos survive the thaw. It's very rare for them not to. Did we lose?
So
Amy?
guys, I don't know. Yeah, we did. We lost Amy briefly. Maybe we heard her feeling. Oh, there she came back to us. There she is. All right. I've got us all back in order here, except for Elizabeth and Amy switched side, but that's okay. But general consensus is that, and I tell clients this all the time, that not surviving the thaw is such a rarity, especially in 2021 with the science that exists and the skill that exists in our labs. And I tell people that a lot. You don't just get to be any old embryologist if you want to work for CNY Fertility. I know that there's a lot of rigor that goes into the training and the development of the skills and the team. So we're going to talk about, somebody's asking about the thaw process, and we'll talk about that in just a minute. But for now, let's kind of move on to this idea of day 3, day 5. So most of our clients are going to get a cryopreservation update, or kind of an update when the cycle is complete. What happens if that day falls on a Sunday? I get that question a lot. Amy, what's the takeaway?
So embryology will be checking your embryos. Your embryos are just fine, even on Sundays. Embryology comes in and we check your embryos. We'll freeze your embryos if need be, if it's time. You'll get an update the following day. On Monday, the teams have been instructed to web correspond with you, and you'll get a little web message from one of our team members, along with a cryo report with grading and pictures as well.
Awesome. So the takeaway is you guys are there. Just because we don't answer the phones doesn't mean we're not all there.
Yeah.
Yeah. So your embryos are always in good hands. I like to joke sometimes. I have an IVF son, and he has the T-shirt, or people have seen, that says my first babysitter was an embryologist, and then it's totally true. I don't know that that's as a high enough of a title, but it's a pretty cool title that you all have.
We take pride in that title, so we're there.
Yeah, no, that's what I think the consensus for most embryologists that I know is that it's a pretty lofty role to get to play in bringing new life into the world. So it's pretty awesome. You guys are amazing. All right, Elizabeth, help our clients understand, why can't we inject every egg that we retrieve? And when I say inject, I mean inject with sperm. So maybe you can kind of explain what that even means.
Yes, certainly. This is so hard for us. I feel like after the retrieval's over and the client hears how many eggs they have, it's so hard. I want people to understand that just because we collected that many doesn't necessarily mean we can inject that many. So the oocyte goes through the process of meiosis. So it's going from a germinal vesicle into metaphase 1 and then into metaphase 2. So the M2 is what we call a mature oocyte. It's at the stage of development in which it's ready to fertilize. It's ready for that sperm, and it's ready to make a zygote. It wants to be fertilized. So if it's at the GV stage or the M1 stage, it's not at the proper stage of meiosis for fertilization to occur. So we are doing the egg harm by injecting it with the sperm. Nothing's going to happen. It's biologically, scientifically, however you want to put it, it's not right for the egg to be injected. So we look at the eggs after they're collected, we assess them for maturity, and at that point, any of the eggs that have made it to that phase in meiosis, that M2 phase that we're looking for, we will inject with the sperm. So don't get stressed if you hear, only 20 were injected out of 30 collected. That's okay. We're doing what's best for your cycle. Does that make sense?
It totally does. Amy, do you have anything to add? Because I think this is a common question, and as I said before, oftentimes comparison is harmful for us as patients, just because we hear, this many work. Well, why did you get this many injected and this many not? And I think, Elizabeth, you made such a good point, and that is it's not biologically possible. So there's a stage in which an egg can be fertilized, and those ones that don't get injected just don't have that capacity to be fertilized. Is that kind of what I'm hearing?
Yes.
Absolutely.
Yep.
Yeah. Elizabeth did a wonderful job at explaining that. Yes.
Yeah, no, it's such a common question, and so I'm glad we were able to kind of talk about that. Now we're getting a lot of questions, and so I'm going to kind of throw out a couple of the questions, and then I'm going to let you guys weigh in. I'm seeing a lot of people, well, what about this grade? Have you seen this grade make a baby? Have you, how much does grading play a role? And so, Amy, maybe I could bat this one too, because this one I think you guys get a lot. I know I get it a lot. But the question basically is, what is the grading system and what does it mean? And just because an embryo has a poor grade, what is the potential outcome of that versus maybe one that has a better grade, and how much is it related?
So this is a question, and like you said, we get it a lot. So I'm going to start by saying that good, fair, and poor embryos can all make babies. I see it all the time. I've been an embryologist a long time. Poor graded embryos do make babies. So it's basically a beauty contest. There's two sort of scales for grading. The first is for a cleavage stage embryo or a day 3 embryo. And those embryos are graded good, fair, and poor. So a 3 or a 4 is given to an embryo for good. A 2 is a fair quality embryo, and a 1 is a poor. So how do they get qualified as good, fair, and poor? At a cleavage stage embryo, at the cleavage stage, we're looking for embryo, like the cell's size and shape. We want to make sure that they're what we call symmetrical, or the same size, and the present absence of any kind of fermentation. So if there's, and that can be, and it can vary from 1 to 10% to 11 to 25% to greater than 25% fragmentation or asymmetry of the cells. Okay, so based on how they're looking, we assign them a grade. Then there's also a grading system for blasts, and that blastocysts are day 5, 6, and 7. Blasts are when the embryo differentiates or changes into 2 cell lines that we can see under the microscope. The first is the inner cell mass that becomes the baby, and the second is the trophectoderm. It surrounds the inner cell mass that becomes the placenta. So again, we're looking at, the numerity of cells, how many, the tightness and compaction of that inner cell mass, if there's any fragmentation within the trophectoderm, all sorts of things, the size and shape, and all of those grades. All of that to say is, let's say we have 10 embryos. How do Elizabeth and I choose which one to go back first? And so grading helps embryology when we don't have information on genetics, when we don't have information other than what we can see. It helps embryology pick what to go back first.
That makes so much sense. And I think that kind of helps lead into my next question, which is genetics and what kind of role that plays in the lab's eyes. And so what is the genetic testing that can be done on embryos? Why would you do it? And when do you kind of have to decide by? And I guess I'll flip that one over to Elizabeth, since we're taking turns.
Yeah. Yes, that sounds great. I just want to sneak in this story really quick. People get hesitant to transfer back poor graded embryos. And I had this situation come up where someone told me that they had transferred 2 really poor quality embryos back, and they had twins. So don't focus on the grading. It doesn't really mean a whole lot. And I love to tell people that, because they say, I'm not going to transfer it. And I always think, yeah, why wouldn't you give it a shot? We would never freeze anything that we don't think has potential, which is really important for people to know. We wouldn't feel good about transferring back an embryo that we don't think we would maybe. Okay, so that's just like.
Yeah, no, and to piggyback off that, I give my own story a lot of times when people ask, when you guys aren't here and I can't refer to you, which is the same question, do I transfer it? It doesn't look good. I tell everybody that my IVF baby, I was warned, it's kind of an ugly embryo, don't get your hopes up. And he's a really cute kid. So it's very much not related. And I think that's the take home message, Elizabeth. I'm so glad you said it, which is that we don't freeze anything that we don't feel. Those are the ones that we say, I'm sorry, those ones didn't make it, because we're not freezing anything that we don't feel gives you a fair shot at getting pregnant. So on to the kind of the other side of that, which is the genetic testing. What's the value of that? Why do we do it? And, when is that process? When is that decision made in the process?
Yeah, so I definitely always refer guys to speak with the provider. Dr. Kiltz, obviously has opinions about PGT, and he makes really great points about it. There's a lot of information supporting it, and there's a lot of information against it, because we do sometimes transfer back abnormal embryos. If you're willing to transfer back an abnormal, is it to go through the process of PGT testing? My and clients always, we would recommend PGT testing for three reasons. 1, multiple miscarriages. 2, advanced maternal age. And 3, if you have a known genetic disorder that you don't want to pass off to your offspring, if that makes sense. So we would certainly recommend it for 3 reasons. It's also certainly fine just to say, I want to transfer back a genetically normal embryo or a female or a male, that is certainly fine. You don't have to, justify to us why you want to do it. It can just be a selective reason. But I just wanted to let you know what circumstance we recommend genetic testing. It's certainly something we'd like you to have information on before you go for your retrieval. It's really important for clients to have all of the information regarding pricing, because it is an additional cost to have testing done. And there's also additional consents that need to be signed before we're allowed to biopsy your embryos. So having all of that taken care of prior to retrieval is very, very important. Usually if people are back and forth about testing, it's better to err on the side of caution and just get all of that done. If you only have a few to work with, and you decide, I only have 2 embryos, I don't want to hold them to blast and biopsy them, no problem. On day 1, when the clinical team calls you and says, you had 2 embryos fertilized, do you still want to, proceed with PGT? You can say no, and we can cancel that PGT. So we'll just freeze. But we just want people to be prepared for PGT if that's what they choose or think they may want to do. PGT, is definitely a more advanced procedure for the embryology team. We're taking, around 5 cells off of the trophectoderm line of cells, which means we actually have to have access to the embryo. And because of us needing access, we do assisted hatching on day 3, so that we can biopsy the embryo on day 5, day 6, or up to day 7 when the embryo has reached the blastocyst stage. So with that being said, I'm kind of just expressing the importance of knowing you want to do PT so that the embryology team can be prepared to do that biopsy for you and have everything organized and ready to go.
Yeah, such a good point. I'm really happy that you brought that up, because that's pretty much the same thing I say to clients as well, is if you think you might want to do PGT, let's get all of the paperwork and let's get all of everything in place. That way, if you choose to go that direction, great, we can. It's not a scramble. And if you change your mind at the last minute, then that, with that fertilization call or whatever, then that's certainly fine as well. But always best to err on that side of if you think you're planning on it. So I'm glad we're on the same page with that. Well, I think you said it, but can you expand on, do we routinely discard abnormal embryos, or what's the process for that, Amy?
No, we do not discard abnormal embryos without the parents' consent. So the client parents, the client and their partner would have to sign a written consent saying that they'd like them discarded. They are your embryos, so we will not discard them if they are abnormal without it.
Yeah, that's such a good point. I tell people that all the time. We're never going to discard anything unless you have consented to that. But I think some clients have come to us from other places where maybe that is the standard procedure. And so I think it's really just good and important to remind everybody, like you said, that those are your embryos, and we're never going to do anything with them without your consent. So that's such a good point. Who wants to, I'm going to see which of you would rather talk about fertilization when it comes to the things like, I know the Zymo chip is there's a lot of chatter about that now. And then things like ICSI versus PICSI. Amy, do you want to take that and kind of explain the differences and why we might choose one over another?
I would start to say that ICSI is our standard at CNY, and the reason we do ICSI is to maximize the number of fertilized embryos. So ICSI would be our standard at CNY. I am new at Zymot and PICSI. Full disclosure, Zymot is a device that we use typically if a patient it's a separation technique for sperm. And it's a dish that uses a membrane, and through that membrane, the motile sperm fraction is taken from. And maybe Elizabeth can talk about Pixie.
Yeah, great.
Yeah, that sounds great. I think that there's definitely been a lot of confusion. There's been so much talk about the Zymot device. It definitely is something that we can make available if a patient would like it. But it doesn't necessarily have anything to do with ICSI. It's before ICSI. This is used to wash the sperm. Basically, Zymot is saying that their device helps pull the best, most sperm through the membrane, the pores, up into the top portion of the membrane where there's fresh media. And then we use that to do the ICSI later. So it's not really doing anything to the actual ICSI procedure. I suppose we would maybe recommend it for someone who has, some sperm wash issues and they wanted to try something different. We can only use the Zymot device for partner fresh or frozen ejaculate. We cannot use it for TESA or PESA samples. The Zymot company also does not recommend using it for extremely low volume sperm samples. So just to kind of clear that up too, so people understand that. So ICSI, intracytoplasmic sperm injection, the ICSI just stands for physiological ICSI. Essentially what we're doing is using a dish that has the hyaluron on the bottom of the dish. So the sperm heads will bind to that hyaluronin and not it just kind of binds. So it'll like get stuck to the bottom of the dish and then we pick up those sperm for ICSI. It's a little bit of an older method. Dr. K treats the lab well, and we have the best of the best microscopes. So we can get a pretty good idea of what the sperm look like, and we can pick up the best looking motile sperm for injection. So we don't really use Pixie all that often. We will use it if a patient has had previous failed fertilization and there's seems to be no egg issue. I just want to try something different. The idea of those sperm binding to the bottom of the dish is that they're mature. They're binding that hyaluron that would be in the cumulus cells surrounding the oocyte. So that's why they're bonding to the bottom of the dish. The idea is that they're mature and ready to fertilize an egg. But like I said, not really something I would recommend. It would be a case-by-case basis. If you're a first-time IVF client, it's not something that we would probably recommend. It just, if you've had those failed fertilization cycles or very poor embryo development, maybe you had fertilization but no embryo development. Does that make sense?
Yeah, no, that makes absolute sense. And I kind of give the example about it's funny because I've always heard it called the Zymote chip, but Zymote, tomato. But I kind of explain that one is it sort of mimics the female reproductive tract in terms of sort of filtering out or sort of only allowing the strongest of the sperm to sort of make it to the other side. And like you said, it's not something that we use for everybody, but it's certainly something that if you have questions about whether or not it would be applicable in your case, like Elizabeth said, some of this, while so much of this is science, there is a lot of it that is art, and that is, if like you said, if we've done these things and not gotten quite the right result the result we were hoping for, some of these tertiary things are methods or options that we can introduce if we're looking for something that we maybe can change to improve the outcome.
And I would just add too, as a standard in our andrology department, to separate the male sample, we use a sperm separation gradient. So we are separating out the motile fraction through a wash step, through a gradient and a wash step. So we're purifying and capturing the most motile, hopefully healthiest sperm that we can. And then, as Elizabeth mentioned, our equipment is outstanding. So my microscope can see the most handsome guy the most handsome sperm to pull out for injections. And so we're able to process those in such a way, very, very well.
Yeah, no, and that's such a good point that, Pixie is a much older technology, I guess, if you want to call it that, or an older process. Whereas now it sounds like you're saying maybe not quite as necessary, given the equipment is so great that you can kind of do the same thing without that extra step, in that you can kind of, like you said, anoint the most handsome of sperm and choose them. So it's a great point. How would you guys, Elizabeth specifically, how would you say morphology plays into ICSI? Does it? And kind of pigtailing off of that, what role do you think overall semen analysis plays, given that we can perform ICSI on all samples?
Yeah, that's a great question. So I have to give a shout out to one of our Syracuse embryologists, Olivia. She just sent out a message to everyone with an update. She definitely reads a lot of articles because we want to stay up to date, and she always gives us some information when she finds something new out. But they're saying now that maybe how the sperm isn't as important as we thought it was. We certainly will take when Amy said the most handsome or the best looking, we're essentially looking for embryo or for sperm that looks normal, nothing with two tails, nothing with missed heads. Sometimes they swim in like a circle. We want to be forward moving. So it is definitely important because we want to find some that are normal looking. So I would say, to answer your question simply, we want mostly normal looking, but I think that if we want to get nitty gritty, that's not as important as you think it was. There's definitely lots of research being done about, sperm morphology. All of our offices do semen analysis with the technology that we do have to build good sperm. I would say you have, poor morphology, really not an issue for ICSI. We're taking that sperm and we're putting it right in the egg. That sperm does not have to do a lot of work anymore. So, yeah, really as a win. Do you agree, Amy?
I do. And, the beauty of this science is that it's still growing and changing and being researched. And there's so much, for everything that we know, there's so much we don't know. And so it's very exciting. But again, it's case by case, putting those puzzle pieces together and trying to build a family.
Yeah, no, it's such a important thing to remember, is that there is so much there's much that we know, and there's many things that we can control, and then there are a lot of things that we don't know. And I think one of my pride points in terms of being a nurse at CNY Fertility is that we do look outside the box, and we do think outside the textbooks and the things that we know to be true, and we kind of look at those things that could be potential in terms of changing the outcome. I had a couple questions, and I think Elizabeth, you kind of talked about it, but how do you identify if an egg is mature? Is there a specific look that the egg has, or what are you specifically looking for?
Yes, yep, we can clearly see if an egg is mature or not. The germinal vesicle basically has, to not be too scientific, it looks like a circle within the egg with a little dot in the middle. It's very clear to see. The M1 is basically an egg without a polar body. And then an M2 is the oocyte has matured to a point where it has released that polar body. So the egg has basically a little ball on top of it, for lack of a better term, just to not get too scientific, like I said. And you can see that polar body. We always put just for, some more information, the polar body goes at 12 o'clock when we inject with the sperm. So it goes right at the top. So we're always looking for that. So it's very clear to us to see if an egg is mature or not. If you ever have a question too, we work as a team, so we always help each other out if it's hard to tell. Our microscopes, like I said, are amazing. It's pretty clear to see.
Yeah, that's so cool. So thank you very much for sharing that. I think the thing we kind of talked about a little bit earlier, but I think is important, and I'd like to hear both of your perspectives, is this idea of not comparing our outcomes to others, and maybe a specific instance where you've seen that maybe not pan out, and just what your own advice is in terms of why we should not. So Amy, I don't know if you want to take it first.
Sure. I mean, with all of my years experience, I love this science because every time I sit down, it's different. And I say that because I know it sounds cliche, but we all are we're unique. We're like snowflakes. Everybody is a little different. And then you multiply that difference by creating a couple trying to create a baby. So, I mean, every male and female combination creates more differences. So it's very hard to compare cycles. I mean, there's certain scientific threads that we can follow and we can braid together to try to, weave a baby. Things that we know, like the polar body, we know about sperm, we know how to safely, create a culture system that can grow embryos. But with all that said, there's like what we touched upon earlier about there's so many things we don't know. And so every case is different. Somebody, for instance, may be in the situation because their husband, let's say, had a previous vasectomy, and they don't necessarily have any egg issues or PCOS or endometriosis or all those other complicating factors. But there's many, many different things that can play a role. Past history of, your medical history, medications you take. There's all sorts of things that we have to piece together. So it's hard to compare apples to oranges. It's
Yeah, that's, just to pigtail off that, and then Elizabeth, I'll shoot it over to you. But I get asked a lot, well, what is my success rate? What is my percentage chance of X, Y, and Z? And I really feel strongly that it's unfair of us to try to offer a percentage, because while we can aggregate all of our cycles and outcomes and those types of things to determine a collective percentage rate, that doesn't take into consideration. I'll tell people even, your success rate with your current partner would be entirely different than with a donor. Mm-hmm. Or any number of different factors. But like you said, we are, and our embryos are like snowflakes. They're each, and unto themselves, they're unique. They should each have something that we look for. Mm-hmm. Like you said, with the blast, the two cellular lines. But beyond that, that overarching difference is kind of what does make us all unique. And so I think it's a bit unfair to assign any type of statistic. Would you guys agree with that?
I do.
Definitely.
I do.
Yeah.
And sometimes we're looking for patterns in cycles. Like we might see the first cycle, second cycle, third cycle. We might be able to see a pattern that will give us an idea of what to do next time. But it like I said, we're trying to uncover it, and everybody is a little different.
Yeah, as we go. And even too, this idea that a future cycle, I could retrieve this cycle and my eggs might respond or act a certain way. Whereas the very next cycle, we could do the same thing and get, a different response, which is enough to drive you crazy if you're a client just, not getting the outcome you're looking for. But I think it can also offer us hope in that every cycle is different. And that's another thing that I love about Dr. Kiltz and about CNY Fertility, is that we don't lose that hope. We don't lose that sight of, well, yes, it acted this way one time, but that doesn't necessarily mean that's going to be the same on a subsequent cycle. So Elizabeth, what's your sage advice on kind of making those comparisons and whatnot?
Yeah, I think that, it's important to remember that this is not easy, and we don't fully understand that, but we are here to support you. IVF is not fun. People aren't like, yes, I want to do IVF. You're usually here because you're struggling to get pregnant, and we're here to support you and help you on that journey. And it's great to get support on Facebook and on all these social media accounts, but it's just important to remember that you're not here because of the same reason as someone else. I've heard people say, my friend got good blasts and I'm not getting blasts. I want blasts, or I want Pixie. You're here for different reasons, and it's really important to go off of what is best for you in your specific cycle. It's great if you have beautiful embryos, but you also need a uterus that will hold and allow that beautiful embryo to implant. So don't get discouraged if, you have a 4AA, but yours didn't take when someone else's 4AA took on the first try. Some people go through more embryos because they're having lining issues. They're not having embryo issues. Their uterus isn't allowing them to maintain pregnancy. And it's also important to remember that those clients may be having miscarriages, and it's hard for them to see, my 4AA worked on your first try. It's tough. It's tough. And, as far as the embryos go, the sperm play a huge factor. The eggs play a huge factor. It's hard, but women over 40 don't typically have great egg quality. So they typically have to do day 3 transfers. Not necessarily, but a lot of them do because they have lower numbers to work with. So sometimes that skews that day 3 transfers and it makes it seem not desirable. Well, that's really not the case. If you're 44, you're only getting 1 egg, it's going to take more than 1 cycle for a 44-year-old to get pregnant than, say, a 28-year-old that got 2 eggs. You know what I'm saying? So every cycle is just so different. And if you have questions, ask us. We're here to help you. And we want you to get pregnant. I just started a family and it is so wonderful. And now I realize how important this is. I always loved my job and I always thought it was important, but I want to make you a mom. That's what I want. So, we're here to help you, and you can ask your friends for support, but ask the embryology team for advice on what you should do for your cycle.
Yeah, I think that is such an amazing takeaway. And that is that, I always tell clients that you hired us for a reason. You came to us for a reason. And that reason is because of Amy and Elizabeth and the knowledge that they bring and the experience that they bring to the table from the lab side, from myself as a nurse who's seen lots of different cases and different things happen to the different physicians and nurse practitioners that we have. We all have advice and experience and knowledge to offer you that while it's certainly important to have that support from your peers or for other women who are going through similar cycles, it's so important not to use anyone else as a litmus test as to how well you are or are not doing, because it's just not like, I think Amy said, it's apples to oranges, and don't get caught in that sort of rut of, like you said, well, my 4AA stuck and yours didn't. So what happened? We wish it were as simple as something like that, but we know it's not. And we are all very much humbled to be a part of this journey because we know how hard it is. Question that kind of cropped up is, can you guys, one of you, I don't care who, explain to us, what does it mean to thaw an embryo? How is that done? When is that done? And how do we know that when that embryo is thawed, that it has survived? What are those markers that you're looking for? Amy seems keen.
So an embryo thaw, or a frozen embryo transfer, FET for short. When you're scheduled for an FET, that means you have frozen embryos in our storage tanks. On the morning of your frozen embryo transfer, the embryology team has already scheduled it, and we are aware, and we've prepared your dishes a day in advance. And that morning of your thaw, we will thaw your embryo that morning, earlier in the morning. Usually the transfers, happen mid to, later on in the day. So we, first thing in the morning, we get them going and we thaw them in a specific process using thaw media.
Yeah, that's really cool. I I guess this is a different question, but a question that I get a lot, and I would love to hear both of your opinions on this. What's your personal thought or opinion on transferring two embryos of pretty widely varying grades? Because I think there was at one point in the fertility world, there was talk that, oh no, you would never want to do that. One will sort of drag down the other. Or, you hear a lot of these interesting kind of concepts, but Amy, specifically you, what are your thoughts on that? And what's the science say?
I think again, one size does not fit all. So if at CNY, if we have grades of similar, like one step between each other, like a good and a fair, or even a fair and a poor, we err to that side just in case. Severity of grades, we try to avoid. However, each embryo has their own implantation potential. It's not like one says to the other, hey guy, let's do this. We're going to make babies today.
Right.
I'll help you out and I'll help you implant. It doesn't do that. So if the embryo is going to implant, the embryo is going to implant. And so, I sort of feel in my own practice that, I don't think one necessarily hurts the other. I think they stand alone.
Yeah. No, that's a great point. Each one has their own potential for implantation. It's not as if we're giving them too much credit if we think that they're like powwowing and deciding, no, you go, no, you go. So Elizabeth, what are your thoughts on that?
Yes, I agree. If we have the option to transfer back two similar graded embryos together, we would do so. If you only have a good and a poor remaining and you want to transfer two, it is certainly fine to transfer both. We just wouldn't necessarily recommend it if you had another option.
Right. Yeah, that makes total sense. Another question. Oh, sorry. Another question. I'm kind of going to the questions here because I do this every time. Everybody who watches me knows I always say there's going to be plenty of time for questions, and then I just keep talking. So this is a great question, and I feel like there were a couple similar questions in the past, which is, what do we do if the embryo doesn't survive the thaw? And we kind of talked about that's a pretty low percentage, but in the event that it does not, what do we do then? Amy, you want to answer that one? Sorry.
So if an embryo does not survive the thaw, on the rare occasion it does not, if the patient has other embryos available to thaw, we would thaw the next highest graded embryo for that patient. So she would have something to transfer at her FET. At the time of, ID or where we come in and we client ID, we talk to the patient, we would then let her know that one of her embryos did not survive. Or we would call the client and ask her what she would like to do. Would she like us to thaw another? If there's nothing else available, then we absolutely would call right away.
Gotcha. Yeah, that makes total sense. So Urania was the one that asked the question. And so it sounds like the answer is yes, there is time typically to thaw another one. It might push your transfer out by an hour or two, depending on what the circumstances are. But yes, absolutely. So somebody else was asking, Amy, if you're from the Albany office. Amy and Elizabeth are both from the Buffalo office. So they both are spearheading our new team with Dr. Chang in Buffalo. And so they are both going to be your embryologists if you're seen in the Buffalo office. So I think, Amy, you're one of many Amy's at CNY Fertility. So I'm thinking maybe that someone is thinking of a different Amy. So, all right. So let's, I think we have time for one more question. And then we will kind of take it from there. Let's see here if I can find a good one. This is a very good one. Elizabeth, maybe I'll bat this one to you because I do get this question quite a lot, and you're nodding your head. What does it look like if you decide after the fact to do the genetic testing? Is it risky? And what does that process look like if you choose to pursue PGT after your embryos have been frozen?
Yes, we get this one a lot. It is certainly possible to thaw embryos and do PGT testing, regardless of the stage. If they're day 3 embryos, we can culture them out to blast and biopsy. If they're already blastocysts, we would thaw, biopsy, and refreeze. It is certainly fine to do this. It would be better to do fresh embryos, biopsy fresh embryos and freeze. That is the best circumstance we can be in for PGT. It's possible to do it the way. Blastocysts survive the thaw, like we said, greater than 99%. And if you already have good blasts, typically we don't have any issues getting a biopsy and refreezing. It's just that the best scenario would be to do them on fresh embryos. We were on a waiting list because women that are in a stim cycle take priority over embryos that are already frozen, just because you're not in a stim cycle, and it takes a lot of time to thaw, rebiopsy, and freeze. It really does. But really not a lot of issues with that. If you have only poor quality embryos, it would be something we would recommend talking with one of the providers about before moving forward, just to see if it's the best option for you. Did that question come with someone who had a certain number of embryos? Do you know, Elizabeth?
It doesn't look like it. No, it doesn't look like it, but I do get that question a fair amount. In just that, I think she said that she had 3 failed transfers. And that's something that, I get a fair amount of time is, okay, well, I'm young. I didn't PGT test my embryos because I didn't feel there was really a reason to, but now I've transferred several times and I'm not getting pregnant, and that seems like one of those things when we talk about, well, what could we change? I think that's kind of that's the genesis of that question.
Yep, definitely. If there's something that needs to be done in that circumstance, if you're not having success, it's certainly fine to thaw, biopsy, refreeze, and see if we can transfer back a euploid or normal embryo.
Yeah, absolutely.
Just to make sure we're on the same page, we are not doing PGT testing in the Buffalo office.
Yeah, that was gonna be the next thing I said was just as a disclaimer, is that right now we are not doing genetic testing PGT in the Buffalo office. Do you have an idea of when that might happen or not yet?
Not yet.
Not yet. Yeah. So as of right now, no, we are not doing any type of PGT in the Buffalo office. However, if I understand it correctly, and I apologize if I'm putting either of you on the spot, but somebody could go to Syracuse if they know they want to transfer eventually in Buffalo. There would be no reason they couldn't maybe retrieve in one of the other offices. And if they were okay with it, they could have those embryos shipped.
Of course.
And we do that. I mean, we do that all the time, shipping between offices. So that's always an option if you desire your transfer in Buffalo, if that's closer to you. That's another one of the benefits of us having as many locations as we do, is there are options like that. And you guys have gotten shipping embryos, eggs, and sperm down to a complete science by now. I'm pretty sure you guys are best friends with the FedEx delivery driver. So that's something that we do lots and lots and are able to do so safely. So there was one last question. I couldn't let it go. I know I said the last one was the last one, but this one's really the last one. So Kaylin was mentioning 2 day 3 morulas graded good. Do morulas that form much earlier? Do morulas that form much earlier than day 4 have a better chance of making it to blast? Amy, you want to take that one?
Sure. Morulas are the step between a day 3 or cleavage stage embryo and a blast. So what happens with a morula is it's just a ball of cells and starts to smooth over. And then once it smooths over, it starts to differentiate into those 2 cell lines that I was talking about in the blastocyst, the inner cell mass and the trifected arm. So morula, it can. Sometimes embryos are a little quick on day 3, and they are morulas on day 3 or compact masses on day 3. Does it have a higher chance of becoming a blast? Maybe not. I mean, not all. We have to remember that an embryo, like we were going back to, an embryo has its own implantation potential. If it's going to continue to grow and progress, it will. I would say you have to hit the morula stage eventually before blast. So it's a good marker. I mean, it's not a bad thing. It's just a step. just like a day 3 step would be, the next step would be marula and then blast. If it's a little bit fast, I mean, we expect 6 to 10 cells on day 3, but if it's a little fast, it's not necessarily a bad thing.
Right. And that just speaks back to this concept that each of our embryos are unto themselves their own, living beings. And while we can certainly anticipate a certain outcome, we don't necessarily know until that happens, what the outcome will be. Well, I think before we let everybody go, what's the best way? I often get asked embryology type questions, and I don't pretend to know things that I don't. And so I'll often send clients directly to you guys. What's the best way for somebody to get in touch with embryology, and what can they kind of expect in terms of when they might hear back from you? Elizabeth, you want to answer that one?
Yeah, so the best way is to contact us via the patient portal, sending us a web message. We try to check those every single day. People sometimes say they tried to call us and they can't get a hold of us. We can't really answer the phone if our head's in the microscope. And I always feel bad because we're never really intentionally not calling someone back. It's usually because we're taking care of the embryos. The embryos are our priority, make sure that everything's done at the correct time. So yes, patient portal is best to get a hold of us, and we will get back to you as soon as we possibly can. If you have some sort of emergency situation, call the clinical team, call that line that you can get a hold of someone, and they will make sure someone walks down to the lab and says, hey, please do X, Y, and Z for this patient. They want this done, and it's day 3, and today's day 3, just so that, someone can communicate directly with us. But we love what we do, and we love to help you out in any way that you can. So feel free to message us anytime, and we'll get back to you as soon as we can.
Yep, that's such a great point, and that is that if you do have something urgent, certainly please call the office, regardless of what it is about. Obviously, if it's urgent and you are in danger, go to the ER. I have to say that, but if it's an urgent situation or an urgent message that you want to communicate to us or to the embryology lab, definitely make sure you call the office. A member of the clinical team, like Elizabeth said, can easily walk down the hall and grab Amy or Elizabeth and convey that message. But as a general rule, patient portal is kind of the name of the game, and we all the different departments work really hard to get you the answers that you're waiting for. And so, don't hesitate to message that way. Well, I think that's about all the time we have. So I appreciate you both so very much in coming and answering questions. And I know some of the regular viewers that have been asking me for weeks and weeks to bring you guys on board are very grateful. So thank you both. That's everything for tonight. If you do have specific questions about anything we've talked about here tonight, please do message through your patient portal. If you are a global travel team client, please always message the travel team. Obviously, if it has to do with embryology, definitely message them. But when in doubt, send it to the travel team, and we'd be happy to route it to the correct kind of endpoint. And then, absolutely. I hope everybody will join us next week. And until then, everybody have a great night. Good luck. I hope you got the sense tonight that we do truly care about what we do so very much, and we're all invested in the same outcome, which is, as Elizabeth said earlier, to make sure that you all get to achieve your dreams of parenthood. So until next time, everybody have a wonderful night. And Amy and Elizabeth, thank you.